Good morning. Welcome to Medicine Grand Rounds and welcome to the new academic year. I'm really excited to be introducing this series. I first of all want to thank Samantha Murray-Boehner, one of our wonderful chief residents who has worked with me closely to put together an outstanding Grand Round series for this year. New this year, in addition to CME, you can get MOC credit, a credit hour for every Grand Rounds. So this is the most painless way to get MOC possible. Instructions are there. I'm told we've all received at least 2 emails on how to do this. One way or another on your computer, you need to set yourself up to be part of the UW Interprofessional Continuing Education Partnership and get that on. But even if you haven't signed up online yet, if you text this in, you'll be able to start getting credit. There is a kicker here, and that is, and we were pretty generous, and we might even shorten this. If you show up after 8:15, the code no longer works. Okay? Believe it or not, there are some people who show up even later than that, and maybe even leave a little bit earlier. We're not monitoring. You're on an honor system in terms of staying, but you will not get credit unless you're here at the beginning. And please come early, enjoy the collegiality with your friends and colleagues, and those wonderful heart-healthy donuts we serve every morning. So with that, let me get things started and introduce our Grand Round speaker. Subarna Dhital is a graduate of the Nepal Medical College in Kathmandu, where he undertook an MBBS, and then he came to the United States, where he did internship and residency at the St. Vincent Hospital in Worcester, Mass., and was chief resident there. In 2010, we were very fortunate to recruit him to the University of Wisconsin, where he was an outstanding endocrinology fellow. He then went back to Nepal and served as an assistant professor of medicine and biochemistry at the Patan Academy of Health Sciences in Lalitpur, Nepal. He also was involved in the Biomed Diabetes Endocrinology Center in Kathmandu. In 2014, he came back to the United States and served at the Eastern Maine Medical Center, Diabetes and Endocrine and Nutritional Center in Bangor, Maine, before we were very fortunate to recruit him to our faculty, where he is currently a clinical assistant professor in the Department of Medicine, Division of Endocrinology, Diabetes and Metabolism. I will mention that during residency, he met Dr. Yusin Tay, who is also an endocrinologist, and this was a dual recruitment by Vince Krines to endocrinology when both Drs. Dhital and Dr. Tay joined our faculty in 2016. He's published a number of chapters, abstracts, and papers, and he's reviewing for 3 prominent journals. He's involved in a number of professional organizations, including the Endocrinology Society, the Nepal Institute of Urban and Regional Studies, the Nepalese Children's Education Fund, and the Alliance for Healthcare Quality Improvement in Nepal, keeping close to his home and providing important international healthcare there. He's been an active educator, serving as a small group instructor for the endocrinology block for second-year students in the legacy curriculum, and has likewise been involved for group education in the food, fasting, and fitness block for the first-year medical students. Along the way, he's also earned a number of awards. He was Intern of the Year, he was Resident of the Year, he won our Endocrinology Fellowship Award, and he received an abstract award from the Endocrinology Society. He's also revered in his home country, where he was selected as one of 3 innovators in Nepalese healthcare in a special publication in 2014, and selected as a delegate of the Nepalese government to study the health insurance systems in Thailand and the Philippines on behalf of Nepal. So we're really fortunate to have Dr. Dhital on our faculty. And today he's going to provide his first medicine grand rounds entitled Hyperparathyroidism, Beyond Stones and Bones. Please join me in welcoming Dr. Dhital.
Thank you, Rick. I'd like to start with a story of Captain Charles Martell. In 1918, this was a man, 22 years old, who was described as a picture of health. He started having problems with flank pain. He was passing cloudy urine. He was passing sediments in urine. He was losing height. He became pigeon-chested. He had multiple ongoing fractures despite minimal injury. And by 1926, you can see a physical transformation. This man was hunched back. He had multiple deformities. Obviously, he was seeking health care at multiple places for an ailment that didn't have a diagnosis. And ultimately, he ended up seeing Dr. Eugene Dubois at Bellevue Hospital in New York. He was a prominent metabolic investigator. He had established the first metabolic ward in the country. He admitted Mr. Martell and did investigations for months. What he noted was he had high calcium levels. He was passing more calcium in his urine compared to what he was taking. And he saw parallels with what he had seen in experimentation in dogs using parathyroid extracts. And he came to a conclusion that Mr. Martell had overactive parathyroid glands. The metabolic ward used to close for the summer, so he arranged the transfer of Mr. Martell to Mass General Hospital, where he had friends who had interest in parathyroid glands. There he underwent parathyroid explorations and ultimately had 6 parathyroid gland explorations without any success. Mr. Martell by now had developed a keen interest in parathyroid system, and he was described as being found in wards poring over anatomy textbooks. He was convinced that he had accessory parathyroid gland in his chest, and he wanted his chest to be explored. So ultimately, in 1932, he underwent mediastinal exploration, and the tumor was found and removed. His calcium levels normalized in about a month. For the first time in a long time, he was able to stand up and walk. Unfortunately, he died 6 weeks after surgery from complications of urosepsis. But his experience ushered in an era where we started diagnosing hyperparathyroidism and treating hyperparathyroidism. I find this story particularly inspiring because this is the exact trajectory we follow in our patients, even in day-to-day care. We try to establish the diagnosis by physiological findings, the biochemical and physiological findings. Then only we go for localization and surgery. And sometimes the surgery is still similarly challenging. Today, we'll first try to characterize what is PTH-dependent hypercalcemia. Then we'll talk about lab tests and genetic testing that we use to diagnose primary hyperparathyroidism. Then we'll review the consequences of hyperparathyroidism, what type of end organ effects it can have. Then we'll try to identify when we send patients for surgery. And finally, we'll review the elements of medical management in cases where we cannot do surgery. So hyperparathyroidism that we deal with now is not as obvious as Mr. Martell's. And actually, this is probably the first recorded case of hyperparathyroidism. This is a 33-year-old man from 1770s. And you can see devastating deformities on him. But this is not the type of presentation we start our workup with these days. Our workup typically starts on routine testing for some other reasons. If we look at experience from Mayo Clinic, on the y-axis you'll see the incidence per 100,000 person years, and on the x-axis different eras of testing. The first era is before the introduction of automated chemistries, the basic metabolic panel. The incidence was about 17 per 100,000 person years. The incidence became over fourfold elevated after introduction of the serum chemistry. We probably learned to analyze the results better, and the incidence of diagnosis of primary hyperparathyroidism reduced after that for a little bit. But then, after introduction of osteoporosis screening, the incidence went up again. So, a lot of the hyperparathyroidism that we deal with now is picked up on this routine testing, either routine biochemical testing or osteoporosis screening. And it is quite a common problem. The largest data set we have is from this study from Kaiser Permanente, Southern California. On the y-axis, you'll see the total number of enrollees. For the time duration of 1995 to 2010, they had looked at 1.7 million of their enrollees. Nearly 57,000 of them had at least one episode of hypercalcemia with calcium level over 10.5 milligram per deciliter. This translates to about 3.2% of their patient population, which is quite a large number. Now, if we are to look at what type of abnormalities are responsible for hypercalcemia, we can go back to that study where they found 57,000 patients with hypercalcemia, and using certain eligibility criteria, they selected 40,000 patients. Now, if we take this as 100% of the patients, 63% of the patients do not have elevated calcium on repeat testing. So it's just one elevated value. If you repeat the test, it's normal. The PTH-independent hypercalcemia that is related to malignancy, medication use, those are just 4% of the total hypercalcemia. The rest are PTH-dependent hypercalcemia, either with associated elevated PTH level or inappropriately normal PTH level. So this is the category that we are going to focus on today, the PTH-dependent hypercalcemia. We can use the terminology primary hyperparathyroidism interchangeably for PTH-dependent hypercalcemia. And there is a fairly limited differential diagnosis for PTH-dependent hypercalcemia. It can be from sporadic primary hyperparathyroidism, either because of adenoma, hyperplasia, or very rarely carcinoma. I'll be using this abbreviation PHPT for primary hyperparathyroidism as I go along. The other causes could be inherited variants of primary hyperparathyroidism from multiple endocrine neoplasia or familial isolated hyperparathyroidism or hyperparathyroidism jaw tumor syndrome. It could be tertiary hyperparathyroidism. This is development of parathyroid autonomy in the context of long-standing secondary hyperparathyroidism in chronic kidney disease. And then finally, there could be familial hypocalciuric hypercalcemia, which is from the genetic mutation in calcium sensing receptor or the downstream elements. Now, there's a group of international experts that meet on a periodic basis. They review the available evidence and come up with guidelines. This is the fourth iteration of their guidelines, and the most recent one is from 2014. I'll be using this as standard of care for this talk. So let's start with how to establish the diagnosis and the etiology of PTH-dependent hypercalcemia. So obviously we check calcium levels. A common question we get is, should we be checking total calcium or ionized calcium? The calcium levels correlate fairly well when the calcium level is high, but the correlation is relatively weak when the calcium levels are low. So in general, total calcium is sufficient, especially if you correct it for low albumin level by using the common formula. But ionized calcium is required if you are going to diagnose this entity of normal calcemic hyperparathyroidism, and we'll talk about this a little bit later. And also probably in situations where you have mildly high calcium level, but then normalizes later, that might be a situation where you'd want to get ionized calcium. And as we saw that vast majority of elevated calcium levels are non-sustained, you'd obviously want to repeat the abnormal test to make sure that this is a consistent abnormality. Now, I'm going to spend a little bit more time with parathyroid hormone because there's a little bit of nuances involved in looking at it. So the parathyroid hormone produced from our parathyroid gland is an 84 amino acid molecule. The first 34, the amino terminal 34 amino acids are the bioactive portion of the PTH molecule. But in circulation, you get a variety of PTH molecules. So there's the whole PTH, but you can have serine phosphorylated PTH molecule called NPTH that can actually be quite elevated in primary hyperparathyroidism, severe primary hyperparathyroidism, or parathyroid carcinoma. You can have partially truncated amino portion of PTH called non-1 to 84 PTH molecule. This can be elevated in chronic kidney disease. And then you can have carboxyl terminal fragments of varying length of PTH. So you have this variety of circulating fragments even in normal situation, but in certain situations like chronic kidney disease, some of these fragments could be very elevated. So the PTH acids we have used, there are 3 generations of them. The first generation PTH acids look at the epitopes in the carboxyl terminal. The second generation PTH acids look at a portion of the amino terminal, and the third generation acids look at another portion of the amino terminal. And if we look at what exactly they are detecting from the circulating PTH fragments in normal persons, first generation assay is primarily detecting C fragments. So C fragments can be elevated with chronic kidney disease, or even if there's non-PTH dependent hypercalcemia, C fragments can be actually elevated. So first generation assays are terrible assays for looking at PTH. Second generation assays are primarily looking at the whole PTH, but they're also looking at the partially truncated amino portion of PTH. So that can be skewed in chronic kidney disease. And then we have third generation PTH assays, which are looking primarily at whole PTH, but also looking at this phosphorylated forms of PTH that can be quite elevated in primary hyperparathyroidism. So in the context of primary hyperparathyroidism, the second and third generation PTH assays perform fairly similarly. So either of those tests will be fine. But the problem is what value to use to diagnose abnormality. The initial reference range that was established using the second generation PTH assay called Nichols Institute assay used the reference range of 12 to 65 based on a very well conducted study. But the problem has been that assay no longer exists and has been replaced by multiple other assays. And when people have done studies looking at these assays, in a single patient, you can have a very varying value of PTH that can be up to 3.5-fold different. So the traditional use of distinct cutoffs, where we have thought of PTH of 12 as low, PTH of 65 or above as high, that no longer applies in the assays that we have now. And besides the assay issue, we have a lot of additional variables that can affect the PTH value. The calcium intake status can affect PTH, vitamin D status, age, kidney function, obesity, and race. All of these factors could affect the PTH value. So the guidelines basically throw their hands in the air and say we need more studies to come up with a specific reference range. In the context of primary hyperparathyroidism, the problem is it is still not a big problem because we have this inappropriately normal versus high. So as long as you are interpreting the PTH in the context of calcium values and overall physiology, it is still, you can make a reasonable interpretation. Probably this is a bigger issue in the context of chronic kidney disease where you're trying to achieve certain PTH targets. So now we'll look at how to diagnose specific etiologies or some nuances involved in that. So ultimately what we're trying to do in these patients is trying to select patients who need surgery for treatment versus patients who do not benefit from surgery. And from that perspective, we can actually group patients into two categories. The first one that have sporadic primary hyperparathyroidism or inherited forms of primary hyperparathyroidism or tertiary hyperparathyroidism. We can lump them together as primary hyperparathyroidism, and these are treated with surgery. The second category, familial hypocalciuric hypercalcemia, FHH, is not amenable to surgery. And in our clinical practice, when we see patients with PTH-dependent hypercalcemia, the biggest distinction we're trying to make is, does this patient require surgery? Does this patient not require surgery? And so let's look at how to make the diagnosis of FHH, and then we'll get back to some of the genetic testing for some forms of primary hyperparathyroidism. So FHH was initially described in 1978. On this graph, you'll see on the y-axis PTH levels, on the x-axis calcium levels. The open circles are patients with hyperparathyroidism, closed circles are patients with familial hypocalciuric hypocalcemia. There's a significant overlap, but you can see that PTH levels are typically lower than primary hyperparathyroidism. And they have other additional typical characteristics. Typically, they are familial. There's mild hypercalcemia. Their PTH is normal or high. They have low urinary calcium excretion, and typically they are asymptomatic. And even if we did surgery in this patient, and this is the data from surgery in 3 patients from NIH where they did subtotal parathyroidectomy. The first patient had 3 glands removed, the second patient had 3.5 glands removed, and the third patient had 3.5 glands removed. And there was no change in calcium levels after surgery. So even if you did subtotal parathyroidectomy in patients with FHH, you would not treat their hypercalcemia. We know a little bit more about FHH now. So if we look at parathyroid C cells, they have calcium sensing receptor which detect the level of calcium and send downstream signaling to modulate the PTH production. We know of several genetic mutations in calcium sensing receptor. We call this FHH type 1. There can be downstream elements involved. G protein is one of them, and mutation in GNA11 can cause familial hypocalciuric hypercalcemia type 2. And then there can be involvement of the endocytosis of the calcium sensing receptor. They have described a mutation in AP2S1 that can be responsible for disruption of endocytosis of calcium sensing receptor. So all of this genetic testing are now commercially available, and you can do this to diagnose FHH in appropriate patients. But there's a simpler test we typically use in diagnosing FHH. And this is largely based on the initial data from when they characterized the patients with FHH. You can use 24-hour urine collection and do the calcium creatinine ratio calculation to diagnose FHH, because there's a distinct difference. If you use a cutoff of 1% of calcium creatinine clearance ratio, you'll include majority of the patients with FHH. If you use 2% as the cutoff, if the calcium creatinine clearance ratio is over 2%, then majority of the patients have primary hyperparathyroidism. Between 1 to 2%, there's an overlap, but you can use this finding to make a diagnosis of FHH as well in majority of the patients. Now, let's look at the rest of the primary hyperparathyroidism and specific genetic mutations that can happen in those patients. So, familial hyperparathyroidism and syndromic hyperparathyroidism have obvious genetic mutations like multiple endocrine neoplasia syndromes or familial isolated hyperparathyroidism or hyperparathyroidism jaw tumor syndrome. But how about non-familial cases? And this study from Yale University had looked at nearly 1,200 of their patients who had undergone parathyroidectomy. They included just the patients who were younger than 45, and from that group excluded patients who had familial hyperparathyroidism, and they were left with 86 patients. They did genetic testing in these 86 patients, and 8 of these patients had specific mutations. So that gives us a prevalence of around 10% genetic mutations in patients who are younger than 40 years of age. So you'd consider genetic testing to make a diagnosis of the cause of primary hyperparathyroidism in certain situations. If the patient is less than 45, has 2 or more gland involvement, has atypical adenoma, has family history of hyperparathyroidism, has syndromic manifestations, these are the situations where you would consider genetic testing. So to summarize this section of making the diagnosis, you'd want to demonstrate that the calcium level is repeatedly abnormal and that the patients have normal or elevated parathyroid hormone level. In that situation, you'd get 24-hour urine collection for calcium creatinine clearance ratio. You'd check their vitamin D. You'd check their creatinine to calculate GFR. If the calcium creatinine clearance ratio is over 2%, that would establish the diagnosis of primary hyperparathyroidism. And if you have reasons to believe that there might be genetic abnormality, you do genetic testing. If the calcium creatinine clearance ratio is below 1% with normal vitamin D and kidney function, it establishes the diagnosis of FHH. You can do genetic testing, but it's not required. But if you have a value between 1 to 2% with normal vitamin D and kidney function, in that situation, you'd want to test for these 3 genes to look for the diagnosis of FHH. Now, the next section will look at the clinical consequences of primary hyperparathyroidism. The typical consequences we have seen are this classic osteitis fibrosa cystica, where there is salt and pepper appearance of the skull, subperiosteal bone erosions and phalanges, osteoclastomas, bone tumors. These are extremely rare in the U.S. now. They still exist in a good number in countries where there's no automated calcium measurement yet, but is relatively rare in the U.S. The issues we see now are more related to fracture risk, bone density abnormality, and changes in bone microarchitecture. Initially, when this entity of asymptomatic primary hyperparathyroidism started being diagnosed after the introduction of automated chemistries in 1970s, skeleton was thought to be spared. But with the start of use of DEXA scans in 80s, that has changed this notion. We see that bone is commonly involved, and initial studies suggested that there was preferential involvement of the cortical bones. And in this study, they had looked at different sites, and they noticed that radius, which is primarily composed of cortical bone, had the biggest bone density loss. The lumbar spine had a smaller amount of loss. It is primarily composed of cancellous bone, and the femur, which is composed of both cancellous and cortical bone, had an intermediate loss. But the fracture studies that came out subsequently did not agree with that. This is a study from Minnesota. They had looked at 407 patients with primary hyperparathyroidism diagnosed between 1965 to 1992. The fractures were at all sites. And in fact, the commonest fracture was vertebral fracture, which is a cancellous bone. So now we have a better way of looking at the bone microarchitecture. The previous studies on bone microarchitecture were done primarily with iliac crest biopsies, but it doesn't give idea about the generalized bone microarchitecture. And with high-resolution peripheral quantitative CT scan, we can look at microarchitecture at all different sites. And when these types of studies have been done, we see that the involvement is rather generalized. And HRPQ CT might not be readily available in clinical setting, but we can supplement our idea about bone microarchitecture by using this simple test of trabecular bone score, which we can get from the routine DEXA scan. And this seems to perform fairly well. So if you look at the ROC curve, my simplified way of looking at it is if it is on the left side and higher, it is performing better. And the trabecular bone score performs significantly better compared to bone density measurement in predicting fracture risk in this patient. So a lot of these patients, you can pick up microarchitectural changes by just looking at the trabecular bone score as well. The other organ to consider is kidney. Kidney stones are the most common manifestations of primary hyperparathyroidism. In studies, the prevalence of kidney stone is somewhere around 15 to 20%, although the earlier studies showed a little bit higher prevalence. And if we look specifically at asymptomatic primary hyperparathyroidism and do routine imaging in these patients, the prevalence seems to be even higher. In this study, the prevalence was about 35%, so that is quite a high number. So the 2014 workshop that I mentioned earlier recommends imaging to look for stones in all patients with primary hyperparathyroidism. Kidney ultrasound might be the simplest imaging to do, but you can do X-rays or CAT scan as well. Now, the other concern is, does it affect kidney function? The overall prevalence of kidney dysfunction is rather low, and it does not seem to correlate with severity of primary hyperparathyroidism or the presence of kidney stones. And when people have done study longitudinally looking at kidney function in asymptomatic primary hyperparathyroidism patients, so on the y-axis on this graph, you'll see the serum calcium level, and when these patients have been followed over years, the creatinine levels are actually robustly stable over 15 years of follow-up. So in mild asymptomatic hyperparathyroidism, there does not seem to be concern with affecting kidneys. Now, the neuropsychological effects, the non-specific symptoms such as fatigue, depression, memory issues are quite common even if the patient has mild hypercalcemia. And when objective testing using standardized tests for depression or anxiety or memory have been used, there seems to be objective abnormality in patients with primary hyperparathyroidism, even if they have mild hypercalcemia. However, the effect of parathyroidectomy on reversing these changes is rather inconsistent. The first randomized controlled trial, the largest we have, showed no benefit. The second, smaller one, showed some benefit. The third, again a small one, showed some benefit, but overall this is rather inconsistent. Because calcium can get deposited in the blood vessels, cardiovascular effects is another concern. In moderate to severe hypercalcemia, there is increased cardiovascular mortality, but in mild asymptomatic primary hyperparathyroidism, data is rather limited to make any conclusions. Currently, majority of experts would not recommend parathyroidectomy just based on the presence of cardiovascular disease or risk factors. So to sum up the clinical effects, I think it is helpful to look at the spectrum of manifestations that we have observed in different eras. The first era would be the era from the diagnosis in Mr. Martell to the introduction of automated chemistries. This was the time when primary hyperparathyroidism presented with bones, moans, and groans, the terms Dr. Albright used for describing this disorder. Then the 1970s to current would be an era of asymptomatic hyperparathyroidism, where patients do not have classic symptoms, but the abnormality is picked up on routine testing, either biochemical testing or bone density testing. And then finally, there's this entity of normal calcemic hyperparathyroidism that has been described since the early 2000s. So this normal calcemic primary hyperparathyroidism is an entity with normal total and ionized calcium, elevated PTH, and we have to exclude the causes of secondary hyperparathyroidism. It could be a little bit challenging to completely exclude the causes of secondary hyperparathyroidism, but this entity seems to be real based on the parathyroidectomy studies, where there is a distinct benefit of parathyroidectomy in these patients. So now we'll look at the surgical aspects of primary hyperparathyroidism. The obvious question is, when is surgery indicated in these patients? If the patient has any of the classic symptoms, obviously surgery should be done. In asymptomatic patients, we try to use certain criteria. If the calcium is over 1 milligram per deciliter above normal, if the patient has osteoporosis by bone density criteria or clinical fractures, if the creatinine clearance is below 60, if there is hypercalciuria, if the patient has kidney stones or nephrocalcinosis on imaging studies, and if the patient is less than 50. But the guidelines go on to say that you can pretty much operate on anyone if the patient desires, as long as there is no contraindication to surgery. I'd like to emphasize that you want to be certain about the diagnosis of primary hyperparathyroidism, and once you are completely certain, then surgery is never a wrong treatment. But a lot of the times, we are not certain about the diagnosis as well, and in those situations, you definitely want to adhere to the specific criteria before sending for surgery. I deliberately put localization studies on the surgical section because we do not use imaging studies to diagnose primary hyperparathyroidism. These are done to facilitate surgery, and in my practice, I typically don't do localization studies. I actually leave it up to our endocrine surgery colleagues. And the common localization studies that we use are ultrasound, system EV scan, CT scan. Less commonly, you can use MRI, you can use PET scan, you can use catheter-based localization studies where you do venous sampling to localize the site of the parathyroid gland involvement. Now, if we look at how these studies perform, the system EV sensitivity is around 79%. Ultrasound performs fairly similarly. 4D CT scan performs a little bit better. If we look at positive predictive value, all three of them perform fairly well. If we look at correct side localization in single adenoma, system EV scan detects around 70%. Ultrasound does fairly similar, but 4D CT scan does a little bit better. And correct quadrant localization, either upper or lower, it is poor with system EV scan, better with ultrasound, and even better with 4D CT scan. So overall, 4D CT scan performs the best, followed by ultrasound, followed by system EV scan. But typically, we start off with ultrasound because it is non-invasive, does not have radiation. But we have this famous aphorism when it comes to localization. It's from Dr. John Dopman, who is intervention radiologist at NIH. In my opinion, the only localizing study indicated in a patient with untreated primary hyperparathyroidism is to localize an experienced parathyroid surgeon. But the question is how to localize an experienced parathyroid surgeon. And so there's actually data to support how we can find an experienced parathyroid surgeon. This is a study that looked at complication rates based on annual surgical volumes of the surgeon. There's a very definite correlation, and the threshold seems to be if the surgeon operates over 100 patients per year, then that surgeon has the lowest rate of complication. So if you're in the middle of nowhere and don't know any parathyroid surgeons, looking at their annual volume of parathyroid surgery might be a place to start. Now finally, we'll look at the medical management of primary hyperparathyroidism. This is needed when the patient meets the criteria for surgery but cannot undergo surgery because of comorbidities, has contraindications to surgery, has had prior unsuccessful surgery, or the patient does not want to go for surgery. I'd like to point out that from cost-effectiveness perspective, any choices other than parathyroidectomy is a suboptimal choice. If we look at a hypothetical situation with a 60-year-old woman with asymptomatic primary hyperparathyroidism and expected longevity of 22 years, and look at a few different modalities, observation or parathyroidectomy or treatment with cinacalcet, which is a calcium-lowering agent. Cost-wise, observation is cheapest. Parathyroidectomy is a little bit more expensive. Cinacalcet is tremendously expensive. So observation is least costly but least effective. Parathyroidectomy is cost-effective, and unless the cost of cinacalcet came down from, on this analysis, from annual cost of $7,400 to $200 per year, it was not a cost-effective treatment. The same group has done a more recent cost-effective analysis where they have included the fracture risk as well. And when they did that, the parathyroidectomy was the dominant choice. It surpassed any other choices. And the threshold for cost-effectiveness is reached within 3 years of anticipated longevity. So even if the patient lived for 3 years, if you did parathyroidectomy, it would be a cost-effective choice. But you'll still have situations where you need to do medical management, and in that situation, there are a few issues to consider. You'll want to look at calcium intake, vitamin D supplementation, bone density issues, and hypercalcemia. So because these patients have hypercalcemia, and intuitive thinking would be, should we restrict calcium intake in these patients? Because you can argue that restricting calcium would lower urinary calcium and thus reduce the possibility of kidney stones. But the other argument is, if you restrict calcium, you're going to further increase parathyroid hormone level, and that would worsen the bone demineralization. We don't have great studies on this, but there's a small study that looked at this. They divided patients into two groups, those that were taking calcium less than 450 milligrams per day, and those who had over 450 milligrams per day of elemental calcium intake. In the group that had low calcium intake, they gave calcium supplementation with 500 milligrams per day. The other group, they didn't do supplementation. They looked at outcomes 1 year later. So baseline, they were fairly similar, except that the no supplementation group had a little bit lower bone density. But 1 year after intervention, their serum calcium and urinary calcium stayed fairly similar, so it didn't make too much of difference. The bone density actually increased statistically in the group that received calcium supplementation. So the overall consensus we have is there is no reason to restrict calcium in patients with hyperparathyroidism. You'd want to adhere to the Institute of Medicine recommendations for recommended daily allowance of calcium, which is around 700 to 1300 milligrams per day. Now, in vitamin D deficient patient, should we do vitamin D as a replacement is another question, because low vitamin D is associated with worsening of hyperparathyroidism. However, the replacement studies are limited, but experts do recommend modest supplementation with 600 to 1,000 units per day of vitamin D, with the goal vitamin D of 20 to 30 nanogram per milliliters. Then we'll look at some pharmacologic agents that have been tested in primary hyperparathyroidism. One is bisphosphonate. There were 4 clinical trials that came out back-to-back in early 2000s that had fairly similar designs. All of them had used alendronate and looked at 2 years outcome. Consistently, they showed improvement in bone density, but in terms of calcium and parathyroid hormone concentration, there was no long-term or sustained improvement. So overall, alendronate improves bone density, but there is no sustained change in calcium or parathyroid hormone values. Denosumab is another medication. This is a study that had looked at bone density change using denosumab in patients with primary hyperparathyroidism versus patients with primary osteoporosis. The amount of bone density increase was substantially higher in patients with primary hyperparathyroidism compared to those with osteoporosis across all different sites, including lumbar spine, femoral neck, and total hip. So denosumab improves bone density, but the calcium phosphate, PTH, and urinary calcium levels remain unchanged. Then finally, cinacalcet, which is an allosteric modulator of calcium sensing receptor, and it can fool the calcium sensing receptor into thinking that there's a lot of calcium and can lower the calcium values. This was tested in this clinical trial where they had the 1 year of double-blinded cinacalcet versus placebo, and then 4.5 years of open-label cinacalcet. And the summary of the findings from this study was cinacalcet rapidly normalizes and maintains the calcium level. PTH levels decrease mildly, but it never normalizes. And there is no effect on bone density at spine, hip, or wrist. So to sum up our talk today, for diagnosis, if you get calcium, parathyroid hormone level, creatinine, vitamin D, 24-hour urine calcium creatinine ratio, and in certain specific situation, genetic testing, you'd be able to establish diagnosis and measure the patients. There are consequences to asymptomatic hyperparathyroidism that involve bone density abnormality or microarchitecture changes, kidney stones, or neuropsychiatric symptoms. Surgery is the most cost-effective treatment for primary hyperparathyroidism, and there are certain indications when you would pursue surgery. But in situations where you would have to manage these patients medically, you would not do calcium restriction in these patients. You can replete vitamin D, aiming for modest levels of vitamin D of around 30 nanogram per milliliters. Alendronate and denosumab improve bone density, but it does not improve calcium levels. And cinacalcet lowers calcium level, but does not improve bone density. So that is the end of my talk. I'd be happy to take any questions you have.
Thank you very much, Dr. Dhital. I'll ask you to call on the audience and please repeat the questions for the recording.
Yes.
I had a question about acute hyperparathyroidism. Does this still apply that this is not considered calcium and
So if I heard the question correctly, so this is primary hyperparathyroidism, should we?
No, I was asking about tertiary, just because from a nephrology perspective.
Oh, sure.
Those patients, so should we also not restrict calcium in those, but stop calcium supplement?
Sure.
Often they're on active ICD, there's often a question whether we should continue it when there's calcium phosphorus.
Sure.
Or based on what you presented, maybe we should not stop it.
So the question is, in tertiary hyperparathyroidism, should we still continue calcium supplementation that we talked about in primary hyperparathyroidism? I think it does not apply for tertiary hyperparathyroidism because there's no significant handling of renal calcium. So we're not really trying to prevent the hypercalciuria in these patients by supplementing calcium from outside to prevent bone loss of calcium. So I would guess it actually does not apply for tertiary hyperparathyroidism, but I'm not fully aware of if there has been studies done evaluating that. Sure. Yes. So the question is, what is the percentage of kidney stones in patients with primary hyperparathyroidism? So the overall prevalence seems to be about 15 to 20% for kidney stone prevalence. But if you do routine imaging studies, it seems to be even higher. So the recent guidelines, they recommend imaging these patients for detecting kidney stones even in asymptomatic patients with primary hyperparathyroidism. But if your question is, should we continue following up with repeated imaging in these patients to look for kidney stones, I don't think we have any data to guide that. Sure. Sure. Yes. Right. I see. Sure. So the question is, if the patient has recurrent kidney stones, should we be tracking for or checking for primary hyperparathyroidism? So if the initial test for primary hyperparathyroidism is normal, it seems like the patient does not have hyperparathyroidism because you do need some time, some duration of hyperparathyroidism for it to be solely responsible for kidney stones. So if on the initial testing there is no evidence of primary hyperparathyroidism, kidney stones probably is not related to primary hyperparathyroidism. So we don't necessarily screen for primary hyperparathyroidism in general population anyways. So I would say the same thing applies for those patients as well. Sure.
There we go. So,
So one more common question. Can you talk about this concept of routine laboratory testing and the way that you find the calcium? And I think it's interesting because a lot of people might consider that over-testing in the way that you used to look at all disorder, whole EMG panels that include calcium. And now many of us are just familiar with particular electrolytes, for example, or something like that in the testing of patients. I wonder if you have any thoughts about that impact on the fact that we use
So the question is, on routine biochemical testing, we are picking up this hypercalcemia. Is there a role for selective testing? I hope I did justice to summarizing your question. Yes, there is. And actually, if you go back and look at the data that I showed earlier from Mayo Clinic, that's exactly what they did. Initially, they introduced the full automated biochemistry panel, but then later removed automatic ordering, so separated out the elements, and then whether that's the factor that was responsible for the drop in the incidence of hypercalcemia subsequently, that I don't know, but it could definitely have a role, yes. And in our healthcare setup, we still end up testing anyways, so we're still likely to pick up these patients early and not let these patients go on to develop full-blown symptomatic primary hyperparathyroidism. But it certainly seems like there's a little bit of over-testing.
If there are no further questions, I want to thank Dr. Dhital for an excellent grand round. Thank you.